Doctor, we are live now.
Thank you, Manjula. So good evening, everyone. On behalf of the Tamil Nadu Ophthalmic Association, it gives me great pleasure to welcome you all for today's webinar on decoding the ocular image, along with the Young Ophthalmologist Society of India. Ocular imaging has become an indispensable and integral tool in modern ophthalmology, allowing us to visualize the eye with unprecedented clarity and precision. From early disease detection to guiding advanced treatment decisions, imaging continues to transform the way we understand and manage ocular health. In this session, we will explore the latest innovations, applications, and clinical insights that are shaping the future of ocular diagnostics. Our distinguished speakers and panelists will share their expertise and discuss how emerging technologies are bridging the gap between research and real-world practice. I'd like to thank each and every one of you for taking the time off and joining us today. We look forward to an engaging and enlightening discussion that deepens our collective understanding of this rapidly evolving field. Before we move on, I would like to introduce our two moderators. Can we have the slides, Manjula?
1 second, Doctor.
Can you go down? Yeah. So I'll just go down. We'll show Dr. Nivedita first. Okay. So I'd like to welcome Dr. Nivedita Narayanan, who is working at Shankar Nethralaya. She's a senior consultant at Cornea and Refractive Services and Deputy Director at Accreditation Safety and Quality Assurance. And she has several credits to her. She's an excellent surgeon. I know that as a corneal and refractive surgeon. And recently, she has been the recipient of the Elizabeth Blackwell Award, which is given for excellence in teaching. I'd like to welcome Dr. Nivedita Narayanan for her to be a moderator.
Thank
Next,
you.
we go on to Dr. Prasanna Venkatesh. Dr. Prasanna Venkatesh is from Mahatma Gandhi Hospital at Trichy. He is now the editor-in-chief of the Tamil Nadu Ophthalmic Association and also the joint secretary of the Young Ophthalmologist Society of India. He has got multiple prestigious awards. He has got a book published, and he's also the winner of the ASCRS Winning Pitch Challenge. He has got multiple credits to his name and is one of the most upcoming ophthalmologists in India today. I'd like to welcome you also, Dr. Prasanna. I'd like to request both of you to take over the proceedings. Thank you.
Over to Nivedita, ma'am. Ma'am, Sujata, ma'am, the introduction of the panelists.
Yeah. Okay, we'll start with the introduction of the panelist. So I'd like to welcome Dr. Rama Rajgopal. She's a senior consultant, cornea and refractive surgery at Shankar Nethralaya. She's got 50 scientific publications. She's also an expert in ocular adnexal and surface lesions. And she's got about 29 years of clinical expertise. Next, we go on to Dr. Muna Bende. I think this name is universally known to everybody. She is a senior consultant and director at Sri Bhagavan Mahavir Vitru Retinal Service, Shankar Nethralaya. She's fellowship trained and she has got 120 peer-reviewed publications. Her special interests are retinal imaging and inherited retinal disorders. She's a member of the Macular Society, VRSI, INTRIS, and AOS. I'd like to welcome you, Dr. Muna. We'll go on to the next panelist, Dr. Sriram Gopal. He's a consultant ophthalmologist and vitreoretinal surgeon. And this is exactly what he has given, so I cannot go any further. But knowing him, I know that he's a very capable vitreoretinal surgeon, an excellent speaker and orator. And at present, he's a treasurer of the Tamil Nadu Ophthalmic Association. He just finished a stint as a secretary of the TNOA and has got a lot of grit. Is one of the wonderful vitreoretinal surgeons that I know of. We'll go on to the last panelist, Dr. Murli Ariga, again, a very well-known name in the field of glaucoma. He's a director and consultant to Swami Eye Clinic and Sundara Medical Foundation. He's an expert in glaucoma management, mixed surgery, and advanced cataract surgery. He's got 44 publications and 15 book chapters. And he's got received the IGO Silver Award, the Best Paper Award, and so on. His credentials run into miles. I'd like to welcome Dr. Murli also to this expert panel. Thank you. We can go on to the moderators for introducing the speakers. Thank you.
Yeah. The next slide, please. So it's my pleasure to introduce our first speaker, Dr. Karan Bhatia. He is a cornea cataract refractive surgeon, senior consultant from Drishti Eye Foundation, Meerut. He is also the vice president of YOSI. He has won gold medals. He is interested in teaching, especially live surgeries. He has attended and presented in multiple national, international conferences, been a faculty of advanced surgical training. So it is indeed our pleasure to listen to him. He is going to speak on pentacam tomography in refractive surgery. On to you, Dr. Karan.
Thank you, ma'am, for the kind introduction. I'll get straight into the topic. So are my slides visible?
Yes, yes.
Yeah. So as I said, and I would thank Sujata ma'am, Prasanna, Nivedita ma'am, and everybody from TNOA for this wonderful opportunity and a wonderful collaboration between TNOA and YOSI. So I'll be talking about corneal topography in refractive surgery. So when and why, as the answer is already there, you want to rule out keratoconus and you want to plan a safe refractive surgery. So the earlier topography devices were all Placido based and they had a lot of errors. If you compare, this is a review article which compares the OpScan, the Pentacam and the Galilei. The OpScan is a scanning slit and Placido based, and the Pentacam and Galilei are a little bit higher. What we commonly use are the Pentacam, Galilei, and the Sirius. The Pentacam is a single Schlimmfuck device. The Galilei is a dual Schlimmfuck with Placido, and the Sirius is a single Schlimmfuck with the Placido device. What I commonly use, I use a Pentacam and I use another device which is the Scansys, which is also a Schlimmfuck imaging device. However, the Pentacam is the gold standard and we need to compare all our data with it. So how is the pentacam different? It's basically the primary source of data here is the measurement of the height. That is that the elevation is the anterior and the posterior elevation is measured and the curvature is calculated on the basis of it. So it has the Schlimmfuck image, a 3D chamber analyzer, a cataract analyzer, pachymetry, and a corneal topography. So 5 things make it a pentacam. So this is the concept of the reference sphere. If you see the prolateness of the normal cornea causes it to rise above the reference sphere. The sphere would be the blue, the cornea will be the yellow, and this results in the central hill, which you can see in the topography map over here. The immediately surrounding the central hill is an annular C, which shows in blue color, and this is where the cornea dips below. And in the far periphery, the prolate cornea again rises up, and which gives a peripheral islands. So the color coding is one that one needs to understand. Anything hot and one need to get alarmed is towards the red side. Anything blue is on the lower values. So you need to exclude a contact lens use. Scleral lens for about 2 weeks should be avoided, and a soft contact lens for about a week. Misalignment, large angle kappa, dry access or excess tears, an opacity or a scar, previous corneal surgeries which can cause erroneous data. So this is what a pentacam looks like, the front and the back. So let us go to the things that the first is the QS. I'll go all of these things into detail. The second is the Kmax. The third is the Thinx location. The fourth is the y-axis deviation. Then you have the anterior chamber depth, with ideally it should be internal that you should select over here. The Q value. Then you come to the quad maps, that is the axial map. Then you have the elevation, the front and the back elevation maps. And then you have the corneal thickness map. This is the second part where 11 you have the corneal thickness spatial profile and the percentage tissue increase PTI, and then you have the bad display, and then you have the holiday EKR, and then you check for the inter-eye corneal symmetry. This is what the holiday EKR. I'll get into details a little bit later. So the QS or the quality specification is tells you how good or reliable the scan is. This is how it should be. If it shows yellow data, that it's not reliable, or if it has a red thing, this is what you should not consider, and this is a bad scan. Kmax ideally should be less than 47.2. The thinnest location should be more than or equal to 470 microns, and the y-axis deviation should be less than 0.50 millimeters. The anterior chamber depth is very important while planning. The internal anterior chamber depth is very important in planning, particularly phakic aisles. The Q value is a measure of the corneal disparity, and it is generally from 0 to -1. It is a key parameter for understanding the cornea's optical properties. So when you look at the quad maps, what you do is you look for the red. So here, this is the anterior sagittal map or the axial map, and you can see a symmetrical bow tie pattern. Other patterns that you can see are the round pattern, the oval pattern, the symmetrical bow tie, as you saw. And this is the superior steepening. This is the asymmetrical bow tie with superior steepening. This is the inferior steepening, an asymmetrical bow tie with an inferior steepening. This can be somewhat categorized as an asymmetrical bow tie without any skewing. So the skewed axis is something which is more than 21 degrees. You draw a line through these two areas, and if this angle is more than 21 degrees, it is an indication that skewing is there, which is a suspicion for keratoconus. Other shapes that you can get is a butterfly, a crab claw, a kissing bird, a vertical D. You can get some irregular shapes in case of a scar, a previous surgery, or in cases of pterygium. The elevation maps, this is what they look like, the front and the back. You can get central islands, you can get an hourglass. So if in case is less than 12 microns, it is normal, the anterior elevation. The back elevation, if it is less than 15 microns, it is abnormal. Any values more than this is something that you should suspect keratoconus. A thickness map, this is where the thinnest location, and you can also see this on the as a circle on the squat map. This is the x-axis deviation, and this is what shows the y-axis deviation. So you get a dome shaped in case of keratoconus. However, you can get a bell shape in case of PMD. A keratoglobus, you will have a uniformly thin cornea, extremely thin cornea, and this is how it looks like. Now this area, this is the thickness map. It shows this is an area of localized thinning. In the thickness profile maps, anything I would suggest is anything red is what you should think of, like this, and that's where you need to get a little bit alarmed. Now coming to the concept of the bad display. Now if you look at this over here, this is the sea level, and if you are comparing two mountains, mountain 1 and mountain 2, from the plane of the level is level 1, that is the sea surface or the lake level, then the difference between mountain 1 and mountain 2 would not be much. However, if this lane is raised to the level at the line at level 2, then the difference between mountain 1 and mountain 2 would be accentuated. And that is the concept of the bad display. Therefore, instead of a shape like this, you will get a shape like this, and the abnormal cornea is much more pronounced. So this is what a bad display will show, much more difference of keratoconus particularly. So the first line over here is the best fit sphere. The second is the enhanced reference surface, and the difference between the two for the front and the back is what you would see in the third row. So let's look at this scan. This is a scan that you would get in a pentacam, and let us analyze. And this is the holiday EKR. So let us analyze the holiday EKR. So generally, holiday EKR is extremely important in such situations. If you get a tall peak over here, this is a good candidate for a toric IOL or a toric phakic IOL where you can plan. This is generally taken at the 4.5 mm zone. However, if you get a flat line, and this is the case where the patient has got irregular astigmatism and will not benefit from a toric IOL. Now let us look at some examples. I'll go to the normal scan first. Now this is the normal scan. So you can see everything, the K1, K2 is fine, the Q value is normal, and you can see that the thinnest location is also 5110. However, the Kmax is 47.9. Internal ACT is good. What you see over here is a asymmetrical bow tie with a superior steepening. There is a sort of a posterior elevation slightly here and not much thinning. Here there is a posterior elevation. This could be a case of keratoconus as you were seeing in the bad display. So this is another example. Let us go for this. So here you can see K1, K2 is abnormal. Then you will go for the thinnest location. The scan is reliable. Obviously, you need to see the age of the patient also, which is very important in managing such cases. The thinnest location is 413. The Kmax is increased. Here you are seeing an asymmetrical bow tie pattern. Elevation areas anterior and posterior. This is usually seen in the central area, and this is coinciding with the area of the thinning, indicating it is going towards keratoconus. And you will see that this difference is accentuated when you are seeing the bad display. So this is a case of keratoconus. Another example over here, the K values are on the higher side. The cornea is extremely thin, the thinnest location of 361. Here you can see that there is superior steepening, that's what we are seeing. The elevation anterior and posterior are coinciding in this area and associated with the area of thinning. Same thing on the bad display, and this is an example, another example of keratoconus. So these patients are not good cases for refractive surgery. Here, what you're seeing is a K2 is on the higher side. The thinnest location you are seeing is 493. K max is on the higher side. You're seeing an asymmetrical bow tie pattern. Slight skewing is there. You can say maybe, maybe not. You can see a posterior, anterior and posterior elevation thinning is there. As you can see, again, this is another case of keratoconus, and these are patients which are not acceptable for refractive surgery. Now let's look at this case. K1, K2, everything is fine. Location, the thinnest location, K max is fine. You're getting a symmetrical bow tie pattern, vertically oriented. Now, the other maps are absolutely normal, and the bad display is also normal, indicating this is a normal case. However, there is astigmatism. That is why you're getting a vertical symmetrical bow tie pattern. So this is a case of with the rule astigmatism, and you can take this up for refractive surgery. This is how ATR or against the rule astigmatism will look like. Oblique astigmatism will look like this. However, this shows some skewing, so you need to look at it. Um, Let's look at another case. K1, K2 is absolutely fine. You're looking, the thinnest location is on the, it's on the thinner side, 446 microns. K max is 46.6. You're seeing an asymmetrical bow tie, slight skewing over here. There isn't much elevation on the anterior posterior maps. However, there is thinning on the generalized corneal surface. So the bad display confirms it that this is not a case of keratoconus, and in such a case, this is a thin cornea. Now, coming to refractive surgery, you can do refractive surgery in such cases, but depends if it's a lower power. My choice over here would be a PRK over a LASIK, and that would be the weight for it. The RSB should be more than 300, and that's you can calculate. This is another case, is a kissing bird sign or a crab claw pattern, and here you are seeing that the area of the elevation and the this is not the elevation and the thinning is not coinciding with one another. So therefore, this is not keratoconus, but this is a case of pellucid marginal degeneration. Now this is another map. Here you're seeing completely blue surface, indicating it is flat. The cornea is slightly on the thinner side. Okay, the elevation maps are fine. So this is the case of post PRK or post refractive surgery. This is another example. You're seeing a blue colored thin cornea over here, no elevation, everything is fine. However, you see this is slightly decentered, so this could be a decentered ablation on a post LASIK eye. This is another case. Now this is you can see a kissing bird sign over here. However, if you see that the area of the anterior and the posterior elevation are there, which are coinciding with the area of the thinning. So this is actually a keratoconus, which looks like pellucid marginal degeneration. So you will call it pellucid-like keratoconus. Now let's look at this patient. Now this patient is a young guy who came for refractive surgery. K1, K2 is fine. The cornea is 522, which is fine. K max is 45.4. What you're seeing on the axial map, remember an axial map gives you a lot of indications at times. This is one example where you will see this is an asymmetrical bow tie pattern, no skewing, no anterior and posterior elevation, no localized thinning as such. So here you can see there is some mild posterior elevation. That is where the bad display comes in. So you can think about it that this could be a suspect, but if this is the only eye and the other eye is like this, I can go ahead with the PRK over here or with the phakic IL, my choice, depending on the number of power. But you look at the left eye now. So the left eye shows an asymmetrical bow tie pattern with skewing. There's anterior and posterior elevation, and this is localized thinning, which is coinciding with the area of the elevation. The K max is 49.7. 494 is the thinnest location, and this is you can see the same on the bad display. The posterior elevation is accentuated, everything is on the red side. This is a right eye keratoconus suspect and left eye keratoconus. Here you would be very suspicious of doing any refractive surgery, and you should not be doing any cornea based refractive surgery. So I'd like to thank Dr. Bellin and Dr. Ambrosio for giving us this wonderful tool to use. Thank you so much.
Yeah, excellent talk.
Excellent.
Excellent talk, finished perfectly on time. You have covered the basics very, very well. I just have two questions to you. One is, what is the highest power that you go in for laser refractive surgery? And in spite of an absolutely normal eye, you would prefer not to do a laser refractive surgery. So the highest limit of the refractive error that you will do laser refractive surgery and not do an ICL. Second question is, do you also do Corvus? Do you also look at corneal biomechanics in your surgical workup?
So the second question I'll come to first is that I don't have access to Corvus, so I cannot tell you much about it. The second thing is, however, the role of biomechanics is there, and the first question is, I generally go up to -8. I have done up to -10 also, but it depends on a lot of factors, not just the thickness. You need to look at the shape, everything, how is it behaving. Any suspicious case above 6-7 diopters, if there is something, I would always go for a phakic IOL. But generally, I prefer not to go beyond 8. For PRK, my choice is always around till 5 diopters. I don't go beyond 5 diopters generally for PRK.
Do you take into consideration the PTA, the percentage of tissue ablated?
Ma'am, I don't take in the PTA. We did a study ourselves when I was in MM Joshi, which shows that PTA is not reliable in Indian eyes. So because the thing, that study was done on placido-based topography. So because now we are doing Schleimpflug imaging and we are using corneal tomography, our pre-op screening is much better than what was shown in the study by in the PTA study by Dr. Santiago. So I don't rely on PTA. I look at RSB and I look at the shape factors. I look very carefully at the axial scan also. That is a big indicator apart from the other maps.
So
Before Dr. Rama asks the question, I think she has to.
Yeah,
I
yeah.
just want one question from you. What will be the lowest you will treat a patient, the corneal thickness, where you will do a PRK? Because generally we limit it to 480. But we saw a case that you discussed, the patient had 454 cornea and you said you will do a PRK. What is your lowest limit?
It'll be, ma'am, around 450, 440 also I will do. But it depends on the power. If it's about -1, 2, 3, maybe I'll consider it. But if it's a higher power, the choice is simple, go for a phakic IOL.
Okay. Dr. Rama, your discussion?
So a couple of points. That was an excellent presentation. One thing that I would like to add, I think we cannot overemphasize the importance of the sagittal map, because the axial map, because that gives you a lot of wealth of information, even in the absence of Corvus. I think that's one map that you have to look at, and the bad screening. About the 8 millimeter, it works fine, but if you have PMD or suspecting PMD, I think you should go for a larger map of 12 millimeters, because that's where we'll scan the peripheral cornea as well. The third point is about Corvus. If I can make a quick comment, I think overall, no investigation is a standalone investigation. You have to factor in the patient factors, the family history of ectasia, the refractive error. Are you going to go for a flap-based procedure, or are you going for a surface ablation? And if you have everything normal and your bad D is borderline, but your axial maps are fine, Pachy is okay, cornea not too steep, you don't have access to Corvus, you can still go for a surface procedure. The problem comes when you have something that is on the higher end, not so high for ICL, but where you have something around 5 or 6 or 7, where you're considering a flap-based smile procedure, where your cornea is steep, where your pachymetry is borderline and your bad D is borderline. Here, I think there are some cues. Sometimes if you have any family history, because recently I saw 3 siblings, one normal cornea, one keratoconus, one in Corvus had, otherwise bad spinning was normal, but Corvus did show abnormality. So there are certain cues that will probably tell you in a regular pentacam and bad screening, but for those who actually have red flag sign, like what we discussed, steep K, borderline Pachy or low Pachy, higher errors, then I think it may be worthwhile considering Corvus.
Can I ask one question? So I just want to know how much of importance you will give to the front elevation in a bad map.
So front elevation is probably, according to me, is less important to me as much if I consider the back elevation. But there are certain situations where the anterior elevation, if you have tear abnormalities and few things like that, then that can change. And you do see that if you repeat it, it becomes all right in some cases. So I would probably take it with a pinch of salt.
We can always have our epithelial maps, which can tell us any front elevation abnormalities induced by the abnormal patterns of epithelium. So we will be able to clench that.
Yeah.
So Dr. Prasanna, I want to introduce the next person.
Yes, ma'am, we'll move forward. Thank you, Karan, for a wonderful talk. I think it was
Wonderful talk.
masterclass by itself. I really loved the mountain metaphorical comparison, and I also personally learned a lot. So with that, we'll move to the next speaker, another dear friend from YOSI, Dr. Urvija Chaudhary, who's currently the consultant and head cornea and refractive services, Rajas Eye Hospital, Indore, and Roshni Group of Eye Hospitals. She's a long-term fellow from NN, special interest in keratoconus silk, and multiple presentations in the state as well as internationally, with awards and accolades, as well as editor of IDOS previously. And she has done publication on TREC, amniotic membrane grafting, and currently she's a trainer as well. So over to you, Dr. Urvija, to have your take on anterior segment OCT.
Thank you. Thank you, Dr. Prasanna. Thank you, Dr. Sujata, for this wonderful opportunity. So I'll just share my screen. Is it visible?
No. No, it's not visible, Urvija.
No? Yet?
No.
Mhm.
Yeah. Now it started to share, but your screen.
Yeah.
So I have been asked to describe a bit on anterior segment OCT. It is a wonderful tool and it makes your work in the clinics quite simpler. In today's time, we have OCT in swept source and spectral domain parts both. Swept source and spectral domain, they work on light coherence, optical coherence tomography. As we have sound waves used in the ultrasound, it uses light waves for the image analysis. My presentation is basically on the swept source OCT done on Cassia 2, and it's used in varieties of cataracts, corneas, glaucoma cases, phakic IOLs, and other parts of the clinic also. So first case is this of a corneal stromal dystrophy. We mostly do DALC procedures for the stromal dystrophies, but with anterior segment OCT, it sometimes helps us to know the depth of the dystrophy. And here we can differentiate or maybe pick up the better option for the patient. If it's a deeper stromal dystrophy, then picking up a full penetrating keratoplasty would give it a better outcome. It's a complete case-based presentation. So we'll go case by case. This second case was of a descemet stripping endothelial keratoplasty. The air bubble was filled till day 3. So we did an ASOCT on day 5 and we saw that there was a slight gap in the graft and the stroma. On deeper evaluation, we also found that there were small irregularities seen between the graft and the stroma. So this said that it was remaining viscoelastic, which must have been sticking behind and not washed off properly, and therefore delaying the graft sticking. So we washed off the interface and rebubbling was again done, giving us a good outcome. And here a simple rebubbling might not have helped. That's what I wanted to point out, that with an ASOCT, you can really see what is the cause of your the gapping in the DSEC graft. Third is a case of a keratoconus. Now, we all know that we talk about epithelial mappings in keratoconus patients, and we know that epithelial thins out at the end, at the cone apex. But that's not always the case. In cases with advanced keratoconus, where stroma really gets very thin, the epithelium hypertrophies at the area of the apex, and this masks the actual thickness of your cornea. And knowing the actual thickness of the cornea may be helping you aid the better decision about doing a cross-linking or a DALC or a scleral contact lenses for your patients. Now, since we were talking on epithelial mapping, this is a new advancement with Cassia ASOCT. They have started giving us epithelial mapping also. So it shows a very typical donut pattern which is seen in the keratoconus patients. And epithelium donut pattern is supposed to show even before you see the changes on the actual topography. The epithelial masking pattern appears much before the keratoconus or the form first keratoconus starts showing up on the topography. So this is a very significant finding. This is a very significant tool which all the anterior segment practitioners should use for their keratoconus patients. And assessing this epithelial thickness mapping over the ASOCT can help you assess your keratoconus progression much before as compared to a topography scans. In subclinical cases also, we can prevent many of post-LASIK ectasia cases if we pick up just simple epithelial thinning. Now going from cornea cases to a very interesting glaucoma case. This patient presented with a sudden diminution of vision with the counting fingers, vision in both the eyes, swollen eyelids, ciliary flush, corneal edema, semi-dilated pupils, and very shallow angle. So it was a case of an angle closure glaucoma, straightforward. Now we have started doing ASOCT for all the glaucoma patients. In this, the pressure notice were 40 and 32 in both the eyes. So on doing an ASOCT, we found narrow angles as predicted, but we also saw there was an increased lens thickness in right eye as well as the left eye. So we did a B scan. There was a ciliary effusion in the posterior B scan image, and therefore we took a detailed history and found out that the patient was using topiramate since 9 days for headache. So topiramate was stopped, hyperosmotic agents and systemic carbonic anhydrase inhibitors started, chronic beta blocker, topical dorzolamide and everything was started with steroids, topical steroids also. So by next day, his pressures came down to 12 and 10, vision slightly improved, and there was a myopic shift. Myopic shift was basically due to the ciliochoroidal effusion. Now in doing all the scans, ASOCT, B scan, here it helped us in understanding the pathology behind that it was a ciliary choroidal effusion causing thickening of the lens, anterior displacement of the lens iris diaphragm, causing a thicker lens, giving a myopic shift, and causing angle closure glaucoma. So on the treatment, patient responded by day 3. His angles opened up, his the lens thickness also reduced very well. So just picturizing the whole thing gives a very beautiful impression and makes you understand things in a much better way. The angles opened up by day 7. Steroids were continued and the vision improved totally by day 30. Fields were fine after the pressures reduced to normal. Now this was again one more case of topiramate-induced acute angle closure glaucoma. Here we saw the same features of increased lens thickness and ciliary effusion was very well noted on the ASOCT images itself. This was also treated on the same line. This was yet another case of topiramate-induced acute angle closure glaucoma with same symptoms. So here I would just wanted to highlight one thing. In bilateral acute angle closure glaucoma cases, we must review the detailed history of any systemic medications. And the best, our cases mainly responded to cessation of the topiramate therapy, topical antiglaucoma, steroids, and cycloplegics. Short-term systemic antiglaucomas were also used, and here we did not really require to use systemic steroids or any kind of peripheral iridotomy, which could have been done in cases of an acute angle closure glaucoma. These are some of the references. Now, yet another case. Here it's a Descemet's membrane detachment. And evaluating on ASOCT will give you a good picture of the position and the amount of DMD we have. So when assessing the area of the DMD, we can decide as to from where we should insert our needle and do the rebubbling to not enter in the space between the DM and the stroma. So after the air fill, it gives us a very good result. ASOCT also helps in pre-op cataract evaluation. This was a posterior capsular integrity evaluation done in a posterior polar cataract, and you could see a very bad posterior capsule here. So just showing this picture to the patient just made the thing very easy. We did not need to counsel him very well. We could just show him on the picture that this is how the eye is and this is complicated and you should be ready for the post-operative outcome. So I wanted to highlight the use of ASOCT as a better understanding to the patient and post-operative outcomes for the doctor. Now, this was a case of phakic IOL. Again, we do ASOCT for all our pre-phakic IOL and post-operative cases. It helps in assessing the vault, the evaluation of the angles post phakic IOL, and also the placement of the lens. Sometimes in initial cases of the phakic IOLs, you may place it in the opposite way, upside down manner. So this can help you understanding the position of the ICL also and the vault analysis over the time and over the years. Now, yet another case of a post-LASIK patient. Here, he got a LASIK done in US, and because of the visual distortion complaint, he gave a history that a second LASIK was also done. Second PRK was done for the remaining power. So he gave history of 2 surgeries. He did not have any records, but again and again complaining of the visual distortions. He was on lubricant since past 2 years by multiple doctors each and everywhere. So me giving him lubricants would not be an answer. So we went ahead, did his eye trace, showed high order abrasions. Decentered ablation was the reason for high order abrasions. So he needed a topo guided correction here for corneal regularization. The vision was 6/6, so we were a little skeptical about as to go for a third surgery or not. But on patient's insistence, we had to decide whether we should do a PRK on top of it, or we could just lift up the flap. Both the things were, we wanted to lift up the flap. So we decided on doing ASOCT, and we saw his flap thickness was good throughout. And I think PRK was not done for him. It was just a confusion given to the patient. So we just picked up his old LASIK flap, did the topo guided PRK, and he responded very well. His higher order abrasions before and after reduced to almost 0.12, and the patient was finally happy with the result. Now, ASOCT also helps in the clinics with the customizing of your scleral contact lenses. It gives you the central clear corneal clearance, the limbal clearance, and helps in precise fitting. It saves time, and it's really good for the people who have just started practicing scleral contact lenses. This case is of a Brown-McLean syndrome after a cataract surgery. This was just for the documentation purpose. We couldn't do much for him. But there is a peripheral corneal edema, which was increasing with time. Every month of follow-up, this thing was increasing. And this is a very rare finding, the peripheral corneal edema post-cataract. Mostly it's seen after ECC initial days. Now, this is a post-traumatic lens dislocation. Again, this good picture helps in counseling your patient, and your work is half done. A scleral limbal cyst, ASOCT can help you assess its connection to the anterior chamber, the thinning beneath the cyst, scleral thinning or connectivity to the vitreous also, or if there is any foreign body which is embedded. So it helps you give a better outcome if you have a good clear picture before you take the patient for your OR. Now, there are whole lot of use of ASOCT in glaucoma patients also, like assessing the angles, lip morphology, and other things. So I would just want to highlight one thing, that ASOCT is a good tool. It simplifies your work in the clinics. It gives you an evidence which creates a confidence in the doctor when you put that picture in front of the patient. It also helps in patient education and counseling also, and therefore a better compliance. Thank you very much.
Thank you, Dr. Vidya, for having a very case-based approach. Handing over the forum to Dr. Amma ma'am and Dr. Nivedita ma'am.
Excellent talk, beautifully shown, nice clinical pictures of various scenarios, and you covered a lot of corneal problems, and glaucoma also. Just wondering, how about the usage in congenital anomalies? Have you also, like Peters, have you had
I
experience?
don't have much experience with
I don't know.
much of the congenital cases.
Yes. It is an excellent tool when you are worried about what is the actual cause, then ASOCT beautifully delineates. So that is one aspect where it is irreplaceable. Without an OCT, your approach, your diagnosis will be totally different. And then with an OCT, your whole idea and the management changes.
Management changes.
Yeah.
For patients, for kids, we do ASOCT sometimes because they are not very much comfortable on the slit lamp with that high illumination, but they sit on the OCT quickly and
Correct.
you can easily evaluate them as much as you want the pictures.
Very true. I just want to ask Dr. Rama, you want to add on something? Your expert opinion.
Couple of quick comments. Very beautiful presentation, really in a short time. So about that interface that you showed, quite often we know that it's fluid, or it can be viscoelastic like you demonstrated, but very rarely when you have an irregularity in the interface, sometimes you can have inflammation or even an infection. So you have to remember to look at your PCR report and make sure that you're not dealing with an infection, especially when you see that hyperreflectivity in the interface, to distinguish whether it's visco or inflammatory component or an infective component. The second point is about how about dermoids. So what happens is whenever you have these solid structures, whether it is, we have done a lot on conjunctival imaging. So whether if it is a solid structure, there's a lot of back shadowing that happens. So in a dermoid, in OCT, while quite often you can make out the lateral extent of it, you are more interested in understanding whether you need a lamellar procedure or a full thickness procedure. Maybe because of the back shadowing, you're not getting an idea about the posterior extent. In these instances, a UBM may be of better help. So there are still indication for UBM in corneal practice when you have densely pigmented lesions, when you have keratinized lesions, when you have dermoid. These are some conditions where, because the penetration is not going to be much, UBM may have a small role to play. And I think even the iris cyst, because you did mention that sclerolimbal cyst, I think even in iris cyst, both OCT and UBM, depending on where is the cyst, will be able to help you understand the extent. And even while you can even do OCT guided aspiration. When you do it, you'll know to what extent your collapse is and what is your endpoint in these eyes.
Sure. Thank you, ma'am.
Dr. Sujata, you want to add something?
You're on mute, ma'am.
You're on mute.
Dr. Urvija, can you stop sharing your screen?
Yeah.
It was a fantastic talk and just like what we wanted, case-based, so it'll be interesting to everybody. Really did a good job, and I think we'll move on to the next talk. Thank you, Dr. Urvija.
Thank you.
So we are now switching gears. So from cornea, we are moving to glaucoma. So, and our next speaker, if she can share the slide.
Manjula?
Manjula, if you can share the slide.
1 second, doctor.
Yeah. So our next speaker is Dr. Prasanna Venkatraman. He is from Arvind, Coimbatore, a senior consultant currently working in Arvind, Chennai. He has done his glaucoma fellowship from Arvind, Coimbatore. And he is going to be speaking on OCT with visual fields in glaucoma.
Thank you, madam. Can I share my screen now?
Please.
Is it visible?
Yeah.
Yeah, good evening, everyone. Thank you, Sujata madam and the entire team for the opportunity. So I'm going to talk on OCT RNFL with visual fields in glaucoma. So why are we having this discussion of fields and OCT? So we all know glaucoma is a progressive disease. So our aim in glaucoma is only to catch the fast progressors. So if we're going to catch these fast progressors, our aim is to prevent the visual disability before their death. So that is the main aim. So we all know structural damage precedes the functional visual loss. So there's no point of choosing OCT or HFA over one another. So we have to use OCT when the damage is in the initial stages and HFA when the damage is in the later stages. So this is one patient. So I'll be talking more about the structure function correlation. So this is from the Zeiss platform. So with this structure function, you have both HFA as well as OCT printouts, which are put together. So you have the HFA printouts, the OCT, RNFL, as well as the GCC. You also have this overlap of both. So as you can see, the right eye HFA looks fairly okay. But if you see this OCT, the superior RNFL is totally lost. You can see thinning here in the quadrant, the clock arm map, as well as in the deviation map, as well as in the GCC. So the same thing is happening in the left eye also. So individually, just looking at the HFA, you might miss these things, but when you overlap with OCT, it adds more value. So why are we worried about HFA and OCT? And one more thing is the this mismatch that we have between the HFA and the OCT. So till this many RGCs are lost, you will not have any damage that is visually seen in the HFA printouts. So for the mean deviation to drop, you need so much loss of the RGCs, up to 50% loss of the RGCs. So what we have to remember is to have some meaningful change to happen in the HFA, it has to exceed the normal variability and reach a statistical significance. For that, there is a redundancy. So in that place, OCT helps us. So this is another patient. So right eye is normal. You can see there is good RNFL thickness. There is nothing wrong with the deviation. GCs is also looking okay. Same thing was with the HFA. But if you look the left eye, so this is the classic Deringer's scotoma that you see in NTG. You can also see the central defects that are there. So correspondingly, you have the inverted image where you have thinning in the inferior quadrants as well as in the deviation map. So GCC map is also really helpful. So when you have this structure function correlation, you can pick up things better. So this is another patient. So the first look at this thickness map will not give you anything. But if you look at the deviation map, there is a thinning that is happening here. The quadrant, that's why you should not look only at the colors. So if you look at this quadrant, it looks all okay. But if you see the clocker, there is a thinning that is happening here. So now when you have a thinning, now go and look back at the thickness map. There is an NFLD that is obviously visible. So even if you miss the thickness map, you can always go back after you pick up from the clocker map. So the left eye is easily seen. The NFL is also totally lost here. You can have superior as well as inferior rim thinning, which is obvious in the quadrant map as well as in the clocker map. So one more important thing is the GCC map. So you can see the nice donut pattern in the ganglion cell complex in this right eye. You can see the arted pattern in the left eye. So you can also use this average GC-APL as well as the minimum GC-APL thickness to pick up these abnormalities. So this is the classic split sign. So whenever you see a GCC map, if you have something that is lost, so this is across the horizontal raphe. You can see glaucoma that is happening in both eyes. So this is the classic split sign that you expect in glaucoma. So why is this happening? Because it is these inferior fibers which are really vulnerable to glaucomatous damage. So this is called the macular vulnerability zone. So whenever you're looking at glaucoma, if we have a thinning that is just running across this RNFL into the macular area, we should be more careful. Even though HFA is looking normal, we should always pick up glaucoma and start treatment if we have a change in these areas. So this is another patient. These are two maps from the same patient. So as you can see, right eye is looking okay. It's a large disc. But if you see the left eye, so there is a slit defect. So this is seen even in this deviation map. But the quadrant map is looking okay. But if you see the clocker map, there is a yellow color area. So this patient we just followed up for some time because HFA, everything, IOP was everything normal. But over a year, you can see the change. So this is, though this is not that obvious in the thickness map, you can see the drop in the average RNFL thickness. From 86, it has become 79. You can also see widening of the deviation map, thinning in both things. So same thing happening in the quadrant. So 101 has become 89 and the clocker, what was yellow in 82 has become 75 in red. So this is structural progression in OCT, which happened over 1 year. So if we don't have this OCT, we would have easily missed progression, assuming everything was normal in the HFA. So if you have Zeiss, you can also have another one called guided progression analysis. This is available even for OCT. So what you need is two baseline and any one of the other OCTs will be helpful to identify progression. So same thing, you can see blunting of all the colors. Same thing is also visible in the deviation map. Slowly, all the red colors are popping. Here you can also see the yellow colors popping. So this is progression that you can easily pick up in the OCT. So this is the same thing of the patient by HFA GPA. So here we have not had 5 HFA. So we are having only this. If you have 5 HFA printouts, you'll have the GP analysis. So here, if you see, you are seeing only empty triangles. So here, HFA is not able to pick up progression yet, but OCT has already shown progression. So this patient, you should be more careful and step up AGM based on his baseline IOP. So is OCT really helpful in all glaucomas? No. We all know there is a structure function mismatch. So because OCT floats at 50 to 55 microns, after that you cannot find any meaningful change in OCT. So you have to rely only on HFAs for advanced glaucomas. So after a point, if all the RGCs are lost, what we have is only the remaining blood vessels and the bundles. So that will not help assess progression in a meaningful way. If you are going to use only OCT, HFA will be of help in these advanced cases. So here you can see, so this is another advanced glaucoma. You can see thinning that is happening in both quadrants. So in the thickness as well as the deviation map, you can see in the quadrant map as well as the clocker map. So this is well reflected in the HFA also. So this is advanced. So in this case, you'll use more of HFA than OCT. So you can see the overlap of structure and function. So the same is reflected in the left eye. So left eye is, right eye is worse and left eye is fairly okay. You can see inferior arcuate scotoma and the corresponding superior thinning that is reflected both in the GCC map as well as in the NFL map. So now we have OCT and visual fields, but should we even take fundus photos? So by the extension, should we even look at disc? Yes, we have to look at disc. So because in these areas, OCT, sometimes HFA also fails. So what are you going to do when this patient has glaucoma? So how will you assess progression? OCT and HFA will not help you much in these cases. And one more area where clinical examination, especially disc photos, help is the identification of disc hemorrhages. So any discontinuous red is a disc hemorrhage. So even if you're not picking up in your primary clinical examination, with the fundus photo, if you have some discontinuous red, always go back. So there will always be an NFLT either before or after the occurrence of this ODH. So this is the one place where fundus photo and your clinical examination really scores over all these fancy investigations. So, and it is really important that you don't trust what you see always, because there can be so many artifacts with OCT and HFA. I'm not going to go into all the artifacts. I'll just show a few cases to understand things better. So one look at this HFA shows this is like an advanced glaucoma. And this, if you just don't look at the false positives, this will look like a fairly okay, normal patient. But just correlate with the OCT. So OCT here, there is glaucoma that is happening. You can see change in the RNFL thickness map as well as the deviation map as well as the GCC, but this is not as advanced as the HFA shows, though all the parameters are looking okay. So there is, though the parameters are looking okay, this is not a reliable field because the HFA and OCT is not matching. Same thing goes with the left eye. Left eye fairly okay. You have some thinning on and off, but it's not in the areas where glaucoma occurs. But if you see the false positive, it's as a 66%. So again, this is not a reliable field. So make sure your structure and function always correlates, and your HFA and OCT always matches with your clinical examination. So this is another patient. So where you can see thinning that is happening in in the GCC. But if you see the VFI, it is 81 and it shows abnormally high sensitivity because of the positivity of 21%. Same thing goes in this side also. So make sure you correlate your HFAs with OCT. And again, you can see the high positive rates of 85%. Though this is not a reliable field, I know this is an advanced glaucoma because you see severe thinning in OCT. So even if the HFA tells otherwise, you will know that this patient has advanced glaucoma. Because HFA is not an easy test. Not all patients can perform this test very well. So if you have some clues from OCT and it is correlating with your clinical examination, you can take your decisions based on that. So this is one final case that I would like to show. So this is a patient of TOAG who came to us with one AGM. So nothing really odd. There is some superior thinning that is happening in both eyes. Other than that, it was routine. Did not find any gross temporal pallor, and he had no other neurohistory. So this is the OCT and the RNFL and the GCC. So you can see some blunting that is happening in the superior quadrant in the right eye and both quadrants in the left eye. You can see thinning in both areas. that is reflected well across the quadrants as well as the clock arm map. But when you look at the GCC, you have this classic vertical split. So this vertical split does not happen only in HFA, that can happen even in OCT also. So even if your HFA is not reliable or if the patient is not able to perform HFA, it is a must that you pick up this sign and refer to a neurologist for neuroimaging. So this is the HFA of the same patient. Any classical vertical split needs neuroimaging. So glaucoma does not occur like this. You cannot have 29 dropping to 0 across the vertical limit. This does not happen in glaucoma. So you can have 24 becoming 20, not 24 becoming to 0 across meridians. So this is so classic of a neurological disease. Also, if we have like piles like quadrant and OPI, then also you should be careful. So this is something you should not miss. So any hemi splits in OCT or HFA is an indication for neuroimaging. So I would like to close with this final case. So this is the fundus picture of a patient. So this is a small disc. The first look, you'll not see much. So this looks like some inferior thinning. But if you actually look there, I don't have the red-free images. There is an NFLD happening here as well as here. It's a wedge defect. Even if you miss notch and the NFLD here, it's totally okay. Go to OCT and HFA. See the classic thinning that is happening here in the thickness map, the deviation map, as well as the GCC. Same thing is reflected here as well as the HFA. So it's okay even if you miss something in the first clinical examination, correlate everything. So when you have something in the OCT, again, go and look back, dilate the patient well. If you have fundus photos, that is also totally okay. Now you will see the thinning very well and the corresponding NFLD. Red free images are really helpful. So, if you miss something, so in this case, you can easily miss because of the smaller size of the disc. So OCT and HFA can also help if you miss something so that you can always go back and, take proper care. So these are the pearls I would like to conclude with. All glaucoma patients progress. It's not like you can arrest progression. So with time, everyone progresses. Our aim is only to pick up the fast progresses. And it's really important that you differentiate statistically significant progression versus clinically significant progression. You don't have to treat all OCT progressions and all HFA progressions. Always look at the patient's age and the ability to follow up the stage of the disease and then take surgical decisions. And we all have to remember these technologies and hardwares, both hardwares and software, constantly evolve. So I have shown only the Zeiss platform. There are other platforms. So always be aware of your OCT as well as HFA machine. These machines, OCT or HFA, they cannot be compared across platforms. You can't compare TopCon versus Zeiss. So if you're going to follow up a patient, use only TopCon or Zeiss. Don't cross over. So that is not going to help you much. Always, it's important to combine both structure and function on top of your good clinical examination. So I would like to close with this. So don't let the treatment be more difficult than during the disease. Please don't treat based only on HFA and OCT. So it's always important that you combine everything before taking clinical decisions. Thank you.
Thank you, Prasanna sir. I would like to call upon Murli Ariga sir to start the panel discussion.
Thank you both the Prasannas, and I think the Arvind Prasanna's presentation was amazing and truly an exceptional presentation showing very good examples of structure function correlation. And I think there are very clear take-home messages here. The clear take-home message is that first thing is that early in the disease, early glaucoma, you do more of structural tests. Probably look at the OCTs, the RNFL measurements, and GCC. And GCC, I think he highlighted the importance of GCC. Whenever you can't look at the disc, particularly in high myopia or some disc anomaly or something else in the disc going on, and provided the macula is normal, you can look at the GCC. So look at the RNFL, look at the thickness map, the deviation map, look at the sector, the quadrant, and look at the GCC as well. This is about the OCT. Early on in the disease, you will find structural changes, even including red-free and OCT optic disc pictures are important. Later in the disease, we call this something like it's also called as a tipping point. A tipping point is a place or the point at which some amount of, like he mentioned in the graphs about RGC loss, about being 25 to 40% and 50%. Earlier, when we were students, we were taught it's about 40% or 50% loss of RGCs before you start seeing changes in structure or function. So now we believe with the OCTs, we can actually pick up something much earlier, something like 15 to 25% or even 30%. We start seeing changes in the structure. So structural, the bottom line, what I'm trying to convey is that early in the disease, do structural tests and rely less on the visual fields to pick up damage, because the fields, given the way we do the testing, the test pattern, the test points, the pattern of field testing which you're doing, we tend to miss early disease for various reasons. So generally, early on in the disease, do structural tests, and later in the disease, as you mentioned about the floor effect reaching RNFL loss of 55 and 50 and not measuring less than that. So what happens is once you reach the scleral thickness level, you can't use OCTs in advanced glaucoma. So don't use OCTs for diagnosing, managing, and looking for progression in advanced glaucoma. Use perimetry, and also use perimetry looking at the central field rather than doing 30-2 and 25-2 every time. Start looking at 10-2 and even start looking at size 5 stimulus. So you can look at advanced glaucomas and follow up with perimetry. Earlier on the disease, you use the structural tests. But both structure and function have to correlate. Keep looking at the overall picture and also correlate clinically. The clinical suppose, for example, you have a branch vein occlusion. I've seen many patients, pupils were not dilated. You'll have a branch vein occlusion looking like an arcuate scotoma. There'll be some disc change. There'll be a field loss. People are treated on glaucoma for years, not looking at the entire fundus. So the entire fundus picture, the clinical impression, the entire patient as a whole, intraocular pressure, and look for change over time. I think glaucoma is a bit complex in that you need to put all these variables in together and then analyze and then come to a conclusion, should we treat or not? And like very rightly, the last slide of Prasanna was fantastic, saying that treat the patient and don't over-treat the patient. Treat the patient in such a way that the patient is comfortable, and we try to stabilize the progression of glaucoma rather than to completely eliminate and stop the glaucoma completely. It's not possible, so keep the patient comfortable and sort of stabilize the progression to a point in which the patient doesn't lose visual function over time. I think excellent presentation and a very good discussion too.
Thank you, sir.
Thank you.
Prasanna, your comments?
Yes, just a few points, ma'am. Ma'am, I'm using a combination of Spectralis and Octopus, no financial disclosure. So with Spectralis, currently the emphasis is on decoding the glaucoma module premium edition, which has recently, it's been now more than half a decade. So we are shifting from the Brooks membrane opening horizontal rim width. Previously, the internal limiting membrane and the Brooks membrane would be having a horizontal rim width that was taken as the rim width, but now it has moved to Brooks membrane opening minimum rim width. So with that concept, again going into Octopus combination, I feel that works really well in my hand. So the first point what I wanted to share for the viewers is, so we have the Brooks membrane opening minimum rim width that has come, and that's really helping a lot in picking up a lot of early diagnosis as with OCT. And with combination with Octopus, the basics is always 24-2, check the RNFL, 10-2, check the ganglion cell inner plexiform layer, as beautifully covered by Prasanna sir. Along with that, two other maps which I really see good in my hands is the cluster analysis map in the Octopus, where we get to see what kind of clusters are actually affected. And then when you go back to the OCT or the fundus, we can actually do the structure function correlation with the RNFL with the cluster analysis. And we also have the polar analysis map where how much of pole has taken a hit, especially the notching. So it's mainly like a vertical lines that comes from the pole. And that is again helps a lot in stratifying the disease. So these are the two things I wanted to add. Ma'am, and Sriram sir also had some doubt that he wanted to ask to Dr. Prasanna.
So no, actually, Dr. Murali has actually half answered my question. My doubt was, should we rely more on OCT in early disease and fields in advanced disease? I think you already answered that. But the larger question is, what do you really rely on in very high myopes? Extremely high myopes.
So there is one school of thought that we can use OCT macula GCC analysis for that. For that, the macula should be normal. So you also have a lot of maculopathies in these high myopes. So you just have to, depend on your clinical examination. OCT will have a lot of artifacts. HFA also will have a lot of artifacts.
Yeah.
So if you can get some decent OCT and if you can get progression analysis in that, it is okay. But high myopes, it is really difficult. End of the day, if nothing is
All myopic eyes are presumed to be glaucomatous, especially disc and macula. You can presume that they are glaucomatous, and you can err on the side of treating them rather than not treating them. But like Prasanna was pointing out, that you should probably document everything at baseline and look for the change. Suppose you're not sure, you don't want to treat, make sure you follow up. Suppose there's a change and it really looks like glaucoma and is worsening, then obviously you're justified in starting treatment. But I would prefer to treat rather than not treat when you're having a typical looking or atypical looking high myope, looking very suspicious like glaucoma. Probably err on the side of treating rather than not treating.
Murli, I have
Thank you, sir.
doubts. In patients who are elderly, it's very difficult to get them to do an HPF. So what
Feels.
do we it feels very difficult. They don't want to do it. They repeat it 8 times, 9 times. They keep erring. So
We don't do it.
yeah. So can we use the OCT to for looking for progression?
Absolutely. You can't see when you can't get a visual field done for any reason, if a patient can't sit on the machine or unable to press the button or cannot cooperate for understand the field test. We try a couple of times and we have these situations where we cannot do the field at all. We can rely more on the optic nerve appearance. What I do is we take serial fundus pictures. So that gives you a very good clue as to what is going on. And the OCT is somewhat more expensive and people don't like to be subjected to expensive tests every time. So sometimes we do OCT maybe annually. But we look at the disc photos more often. I probably take a disc photo every visit and not even charge the patient. So that gives you a good clue as to what is going on. When the media is opaque, you can't see, then that's a different issue altogether. We rely more on the pupil and the intraocular pressure. So intraocular pressure, the pupils, the disc appearance, serial photographs, and OCT when you can't do visual fields.
The other thing is, do you still take into account the CCT?
CCT is quite important, especially when you have a normal looking disc, normal looking field, normal looking OCT or something, and you have IOP maybe say between 24 and 26, something like that. So CCT definitely becomes important. But I would generally sort of not treat these 22s and 24s when the thickness is on the higher side. I would tend to treat only much higher pressure, something like 26 and 28, because the OH study and other studies have clearly shown that not treating these OHTs are probably better off than treating them because the morbidity of medication is definitely high. You can consider SLT if you really want to treat OHT. Consider SLT as a good option to lower the intraocular pressure.
Thank you, Dr. Murli. I think we can go on to the next talk. Dr. Prasanna?
Yes, ma'am. Sharing the screen for the next speaker. Next, we would like to call upon the fourth speaker of the day, Dr. Santosh Gopi Krishna. So Dr. Santosh Gopi Krishna is a vitreoretinal surgeon from Narayan Netralaya, Bangalore. And he's with us to talk on OCTA. He specializes in the diagnosis and management of complex retinal and vitreous disorders. Highly skilled in diabetic vitrectomies, recipient of various awards in VRSI and AAOS, and he has published multiple papers, and he's an active member in VRSI and AAOS. Over to you, Dr. Santosh.
Thank you, Dr. Prasanna. I think can you see the screen?
Yeah.
Yeah. And thanks so much for the opportunity, Dr. Sujata and TNOA and Dr. Prasanna. So I'll be talking about OCTA. So it's quite a vast topic. I'll try to kind of keep it as concise as possible. So we know the historical evolution of OCT, how it started, and Octa was a thing that came in somewhere in 2012 and 2014. So Octa is basically an extension of the OCT B scan, what we call the structural OCT. So it adds a three-dimensional kind of view to it. So it's basically different algorithms, and there are multiple scans that are taken per second. It ranges from almost 70,000 to almost 2 lakh scans per second. So this is the principle of Octa. It's basically try to catch the blood flow that happens through the blood vessels, and when it against a static background. But the only problem is when the scan goes through one particular section, there's a saturation limit wherein the blood flow is too fast, or if the blood flow is too slow, it can't catch the blood flow. So it has to be in between that sweet spot wherein it can catch the flow. So there are, if you take a 3x3 section that's focused on the macula, it takes around these many number of scans, 245 A scans per B scan, and around 4 B scans at each position. So what I had worked on is something called OptoView or AngioView. There are many other companies that have Octa now, Zeiss or Topcon or Nidec. So the basic principle of looking at this flow of blood vessels is based on these three main principles, that is called Doppler or phase variance OCT or amplitude based OCT. Now, if you look at AngioView or the OptoView, it's based on something called split spectrum amplitude decorrelation angiography, wherein once you get these sections, once there are innumerable B scans that pass through A scans and B scans that pass through one section, you get these high resolution images which have lots of noise. But to break that into a clearer picture, we need to have these low resolution OCT frames. Then there is something called a decorrelation that is applied, and finally we get this clear-cut images. Whereas if you look at Zeiss, for an example, it has both phase shift as well as amplitude variation. That it's a complex signal that it kind of decodes. So this is a comparison between a full spectrum amplitude decorrelation, where there's quite some noise here. But if you see the split spectrum, once the spectrum is split into low resolution and then again decorrelated, you kind of get a clearer picture of the vasculature. So these are the layers on Octa. A typical Octa, what you see is a superficial, deep, and outer retina and the CC layer, which is a choriocapillary layer. And this is when comparison with the unfast images. Unfast image is the it's a image that you kind of see when it's focused. It's like a wall what you're looking at. So if it's a superficial, this is what you see. This is a deep what you see, and this is the outer retina and the CC. So this also kind of gives a impression, and we can kind of gather quite some information when you look at an unfast. And the basic main important thing is we need to kind of correlate with the OCT B scan, which is extremely important. So coming to the different layers, this is a superficial layer which cuts through from retinal nerve fiber layer till the superficial inner plexiform layer. This is how it is seen. You can see the larger vessels, but when it comes to the deeper layer, DCP, this has from deep inner plexiform layer till the superficial outer nuclear layer. This is the thickest layer, which has around 660 microns. And this is the outer retina. Outer retina is basically, it's supposed to have no blood vessels. It should look dark like this. But if you see any kind of blood vessels, and that means there is something happening there. And this is a CC layer, which is a choriocapillary layer. It's a coarse layer. You just find this coarse architecture. You can see these artifacts, what you can see the blood vessels, which can show, throw a shadow on this CC layer. So these are the typical vascular plexus, what you see. This is middle is another term that has been described in somewhere in between, but the difference between superficial and deep is so less that middle is almost irrelevant. So these are the comparison between different sections of Octa. So you can have a 3x3, you can have a 6x6, you can have a 8x8. Now we can have a 9x9 or even 12x12. But as the size of the Octa increases, the resolution kind of comes down. So you can see a better resolution in a smaller frame. So similarly, if you can see 3x3, you can see what's happening to the vasculature, both in superficial and deep. This is in the 3x3 slabs. So what does Octa do? Octa is basically a non-invasive angiography. So we are trying to get closer to replacing FA or ICGA, but these are two initial stages, though the machine has been around for almost a decade now. So we get a 3D kind of OCT angiography, wherein if you look at FA, it is only 2D imaging. So the extremely helpful part is angio analytics. Each machine has its own angio analytics. Like once the image is taken, you can subject the image to this something called pseudo color. You can get this color coded vascular density. Depending on the red colors means more dense, and blue is like if you see the FAZ, it's more blue. Then you can see the flow index. You can kind of map the scan there, and you can see what's happening to the flow index, both in superficial and deep. You can see the flow area here. It will give a value here, and you can see the non-flow area here, especially in cases like branched retinal vein occlusions or CNPs or even macular ischemias. If you can even look at the size of the lesion in a CNVM, you can look at what's happening to the FAZ. Then again, you can color code these at the macula as well as the disc. So several papers have been published even on peripapillary and the disc changes that happen. So this is the color-coded peripapillary capillary dropout that is seen in glaucoma as glaucoma advances. So these are the differences between SDOCT Octa and SS Octa. Once there's SS Octa, the images are a little more clear because of the number of scans that are taken, and since the depth is more. And we had published some papers way back in 2016 and 17, wherein we had kind of applied some fractal analysis. It's a post-image acquisition analysis, so that to quantify these vasculature, what really happens. The problem is, since there are these number of scans that happen, almost 70,000 scans per second, the eye stability is extremely important. And since the scan is acquired in fraction of seconds, there can be difficulties and artifacts when the patient moves, when the patient blinks. So you can see these artifacts. These are motion correction artifacts. You can see these horizontal lines. Signal strength kind of drops down. So every machine has an inbuilt technology wherein you can apply an MCT, the motion correction technology, and then you will see a little better image. So there have been software analysis and programs which can kind of correct this. You can have a fast scan in one section and the slow scan in one section, and when you combine these, you get a better thing. And you need to kind of apply these to even eye tracking motion technologies. Projection artifacts is one of the main problem that Octa faces, because it's like a water that is there over a flat surface. You can see the shadows that happen over the deeper layers. So if you see here, this is the deeper structure, but you can see these vasculature which shouldn't be there, which should be there at the deeper layer. You need to see a deeper vessel. So these are the artifacts that are there as which are called projection artifacts. So there are again different software to kind of take it out. It's called 3D projection artifact removal. You can kind of see this vasculature better. You can remove those artifacts in and around. You can see this image. The superficial vessels are there. Once this is applied, you can see these are gone. You can better delineate the choroidal neovascular membrane. And again, there have been papers which talked about varying the scan depth a little here and there in microns so that you get a better scan without artifacts. Now coming to diabetic retinopathy and diabetic macular edema. So even before diabetic retinopathy starts, there is evidence to say that there is a vascular change that starts happening, and there is change in the FAZ also that starts happening even before you see clinically visible diabetic retinopathy changes. So you can just compare angiography. If you can just see the leakage that's happening in angiography and ONH head level on vitreous level. This is the vasculature that's beautifully appreciated here. You can see it again at different layers, and you can kind of see what really happens once you give an injection, and once you do a PRP, what's really happening to this vasculature, both NVE and NVD. And it's a beautiful tool to kind of monitor the progression of diabetic retinopathy. You can even compare, when you compare an FA image to an Octa image. This is almost a 12 mm image. You can see the drop in vasculature corresponds to the macular ischemia here. And sometimes unfast image also helps. You can see the NVD happening here. So you need to kind of sit at the machine, and we need to desegment the levels and to see what's really happening at what level. So there were papers that we published, and we are seen at different stages of diabetic retinopathy that the vasculature slowly kind of increases in the gap increases as the severity of diabetic retinopathy progresses. There is change in the FAZ also. As severe NPDR and PDR has, there is a higher spacing between the larger vessels. So these are the endoanalytics in DME. When you look at DME, you can see the vessel density, what really happens, FAZ area, vascularity index, and spacing between all these vessels. When you look at a patient with no macular edema, you can still appreciate the aneurysms in deeper layer more than this is a superficial layer and this is a deeper layer. These are the corresponding unfast images. But when you see a cystoid macular edema, these aneurysms are more appreciated in the DCP, the deep capillary layer, even on the unfast also. But it's not that easy to interpret, because if you have such a diabetic macular edema, CM, it's very difficult to kind of appreciate what's really happening at what level. It's a completely distorted image. There are signal quality is poor, so you can't really make out. So just based on these kind of images, you can't really comment on what's really happening on Octa. So this is again a case wherein you see good images, a good responsive DME versus a non-poorly responsive DME. You can see the distorted FAZ and the vasculature also, both on the deep as well as superficial and even corresponding unfast images. So there have been studies that showed that long-standing DME, and when you have the breach in the OPL, this corresponds to the rarefaction of capillaries on DCP. So this is the importance of deep capillary plexus, which is really important because it is the layer which has there happens a synapse between bipolar cells and the photoreceptor cells, and it acts as a real fluid barrier. So any structural damage to that, it results in loss of vision, and this is one of the indicators in Octa that you can kind of take into account. So there are again artifacts when it comes to these macular edema cases. Even a simple hard exudate or something, because of the saccadical movements of the eye, because the fraction of the seconds in which the scan is taken, these are seen as flow areas, whereas these are artifacts. So that also has to be kept in mind. Vessel displacement also happens in diabetic macular edema when there is a fluid that happens. Once the edema comes down, the vessels again, they come back. So this also shouldn't be mistaken for dropout area. So this also should be taken into account. Coming to choroidal neovascularization, it is really again helpful, but if you look at few cases like in SD-OCT, like angio, it's a little difficult to appreciate what's really happening because of the PEDs and drusenioid PEDs. You get these dark areas which don't really represent in a dropout flow. This is a CC layer, but there is a change in the CC layer. Geographic atrophy, again, there's a complete loss of central foveal thickness. So you can appreciate the choroidal vessels, but these are not the CNVM complex. These are choroidal vessels. Now, classic CNVM, it's comparable to Octa, even in cases of both classic as well as occult CNVM also can be easily comparable to Octa. And CNVMs can be monitored. You can see that the presentation, what happens, what changes happen with anti-VEGF injections over a period of time. You can measure these CNVM and you can again follow them over a period of time. Inactive CNVMs, even if you have a flat OCT without any activity, sometimes you can see the CNVM complex. This is a great tool to catch these subtle CNVMs, indeterminate CNVMs, which are in a transition period when patient complains of some kind of vision loss or you're not really sure, because in most of the cases, when you do an FA and ICGA, you can't really catch anything, but Octa really helps in these cases. So there have been criteria that have been published, which says that whether the CNVM is active or not. It shows that once you have an active CNVM, it has to have tiny capillaries, it's fully anastomosed, and it's like a round structure. But once it's an inactive CNVM, you see these long filamentary linear vessels. They are large mature vessels. The anastomosis is absent. It's a dead tree appearance. So these are the criteria that are being published already. And it is again helpful in cases of PCV and BNN. PCV, it can't really catch because of the changes in the blood flow, which doesn't really fit into the Octa specifics. But BNN is really appreciable on Octa. But sometimes ONFAS can help us see where the polyps can possibly lie. So that also is really helpful. And again, as I said, indeterminate CNVMs, you can see the monitoring of the activity. And this is an additional value to the OCT B-scan biomarker. So this is how it can change over a period of time. You can see the finer vessels as time goes with the PDT and all. You can see just the large vessel complex. This is the mature vessels wherein there is no activity at all. MACTEL again is, it really helps in MACTEL, and we had published a paper. So this actually shows the initial phases when you have a doubt what's really happening, some kind of changes on OCT B-scan. You can subject these patients. As the stage of MACTEL progresses, you can see the capillary rarefaction and anastomosis that's happening in the temporal side of the macula. And especially, I find it very important when you want to see whether there's a CNVM happening, because in cases of SRNVM in MACTEL, you just do an FA, you just see a leakage. But if you can really catch the SRNVM on outer retinal layer, even on the CC layer. PAM again this is a really useful tool to see and correlate with the PAM. You can see this middle retinal thickening, and old PAM also you can see the clear dropout in DCP layers. Branch retinal vein occlusion, this really corresponds well to the area where there is loss of blood supply, and you can even see and measure these areas. So this is how it looks like a color-coded map in normal diabetic patients as well as branch retinal vein occlusion. PNV is one of the indication where I have been using Octa routinely. It can really catch these fine vascular complexes, wherein ICG is other entity that can usually catch the chronic CSRs. You can really catch these areas very fast. So the future directions being, as we move towards advances in Octa, we are more trying to kind of replace the invasive angiography with non-invasive angiography. There have been papers wherein they have been using handheld Octa in ROP babies, immobile patients, cardiac patients, and in ICUs. And this is how 3x3, 6x6, 9x9, even 12x12, you can see these plexelite 9000 images, which are color coded. You can see the IRMAs, NVs, and dropout areas. This is the intralight Dream OCT and expensive machines, but it really gives some meaningful images, and you can, it's a very good complementary tool in a clinical side. So Whitefield Octa, there have been papers which kind of try to classify DR according to just based on DR Octa. So these are things we are looking forward to. And even 3D images, you can see the drop in capillary non-perfusion in BR viewer cases. And even in CNVM cases, you can see the 3D volumetric scan. So these are images which kind of are promising to kind of look towards more futuristic dimensions. And the other thing is a variable interscan time analysis, which is a prototype. This is a machine based wherein the interscan times can be varied to see the blood flow, whether the blood is flowing fast, whether the blood is flowing slow. This can be used in both in PCV as well as in DME. This is the latest paper, which shows that which aneurysms have more blood supply, which aneurysms have less blood supply. It's almost coming closer to an angiography, invasive angiography. These are the things that are still in prototype though. So to conclude, Octa is a really good non-invasive modality, but structural OCT B-scan is a must for interpretation. It's safer, it's convenient, and it's the best in central retina and as a really good follow-up tool. It gives a good quantitative 3D assessment, and it's almost comparable to invasive angiography in the posterior pole. But the problem being the cost, the limited availability, the learning curve is quite steep. And there are several artifacts. If the patient can't cooperate, if there is media haze, cataract, or anything, if the signal strength is less, you just can't rely on this Octa, and you can't. It's not a ready printout that you can kind of say that okay, these are the things, and it's again subjective. One person can feel something, the other person can feel something else. And thank you so much for the kind attention.
Thank you, sir. We would like to hand it over to our panel, Sriram Gopal sir and Mona Bende ma'am for the discussion.
Thank you, Prasanna. One thing I would like to add to kind of oversimplification. Octa is something which is very useful when you know where exactly to look for. You can't go search all over the retina with an Octa. Even with the angioplex, it's not that easy. So Octa is generally very useful when you know what to look for and where exactly to look for. You can go and confirm it. But unlike in an FFA, you can't just subject a patient to the test and then try to find out what is happening where. Ma'am, your thoughts, ma'am? Ma'am, you're on mute, ma'am. Thank you, ma'am.
Yeah, thank you, Santosh, for showing us those nice cases.
Thank you.
And I think the main advantage of Octa is, you capture all the images and then you can go back and look for them. But if you're relying on somebody else to give you a report, then you need to tell them what to look for. Like if you're looking for a vein occlusion, then I have my protocol. I tell them, give my RVO protocol. So then they will give you the superficial and deep capillary plexus, which is what we are interested in. And if we are looking at a diabetic, again, superficial and deep. But if we are looking at AMD, then we want to go deeper. So it is time consuming if someone doesn't give you what you want, but you need to also know what exactly you're looking for. So I think that is the main challenge in Octa. And once you realize that, then the learning curve is fine. Because now we have, in fact, the Plex Elite now has a 15 by 15 single picture, which has just come in. Unfortunately, they take a lot of time. And unless your patient has a very good fixation, you won't get a good picture. And artifacts and segmentation and choosing wisely. Sometimes we say, yes, let's do a 12 by 12, but you can miss a lot of things in that. So depending on what you want, I think a big advantage is finding out asymptomatic CNV in the fellow eye. Not that you're going to treat them, but at least you can warn them to come back to you earlier, especially if the other eye has got a disciform scar. So,
Thank you, ma'am.
We'll now move on to the next speaker.
Yes, ma'am.
Yeah, so can you share the slides?
Yeah.
So this is Dr. Shashwanti Mogan. She's working as a vitreoretinal surgeon in Dubai right now. She is a very dynamic personality, published already in many publications, chapters, and she has done her fellowship from Shankar Nethralaya. She has won many awards. She has been an ophthalmic hero, rising star, and many more. So I now welcome Dr. Shashwanti Mohan to speak on B-scan. On to you.
Thank you, ma'am. I'll share my screen now.
It's visible.
Yeah. The big screen is visible, right? Yeah. So I think MB ma'am knows that it's one of my favorite topics, ultrasound B scan, the posterior segment. I think old is gold. We have seen all the latest investigations, but sometimes we need the older investigations. So I'll just go through the principle quickly. The B scan is a brightness modulation scan. It gives us a 2D cross-sectional image of the eye. So the brightness intensity is proportional to the echo amplitude. It acts on the pulse echo system. So what happens is an electric pulsar source generates an oscillatory signal, and a piezoelectric crystal in the transducer is simulated, and a resultant sound wave is projected onto the ocular tissues, and the reflected echo is collected by the transducer, and these echoes are amplified by the strength and according to the receiver, and then a 2D display of the tissue is put on the monitor, which is the B scan. So usually for a posterior segment, we use about 8 to 10 megahertz. That's the hertz that we use. And just quickly going through what the orientations of the B scan that we do. One of the main ones is axial scan, where we are able to see the optic nerve. So the eye is in the primary gaze and the probe is centered on the cornea, and it gives us the sound beam is directed to the center of the lens and intersects the optic nerve. And that's good for axial length measurement. The other orientation is transverse, which is the most commonly done. It gives us 6 clock hours, depending on which direction of in which direction we're looking at. And in every screening ultrasound, we should do an axial and 4 transverse scans. So the last one is longitudinal, which is not done as frequently as we do the other scans. In this, only 1 clock hour, that is the anteroposterior extent, is given, especially important in tumors and in retinal tears as well. So indications for B-scan, we all know it's absolutely compulsory in an opaque ocular media where we cannot use OCT or anything else. So this can be due to an anterior segment opacity or a posterior segment opacity. But it's also useful in clear ocular media especially in the anterior segment, if we want to diagnose any iris and ciliary body tumors, or in the posterior segment, if you want to differentiate between exudative or regmatogenous RD, intraocular tumors, intraocular foreign body, any optic disc anomalies, and any choroidal detachment to differentiate between serous and hemorrhagic, in posterior scleritis where it is diagnostic, and in ocular trauma. So we need to look at the normal B scan first before we go into what is abnormal. In a normal B scan, the vitreous is echo-free. There should not be any opacities in the vitreous usually, especially in children. And there's a smooth concave retina within a very normal optic nerve head shadow. So the retina choroid and the sclera are not seen separately. They're seen as one RCS spike. So coming to a few case discussions, this is a 75-year-old patient with a total cataract in the right eye with PL positive. He's a known patient of diabetic retinopathy, and the left eye is showing signs of PDR. So there's no view of the retina in the right eye. So if you look at this scan, would you think it is vitreous hemorrhage? Because other eye is showing signs of PDR. So we need to make sure the prognosis for the patient after cataract surgery, or whether it should be a combined surgery, the patient should be aware of this. So there's multiple homogeneous densely packed medium to high reflective dot echoes with a clear space between it in the retina. Can you see the screen? Sorry, I think. Yeah.
Yes, we can see this.
Yeah, it's fine.
Yeah.
Please go ahead.
Yeah, okay. Between it and the retina. So this is asteroid hyalosis. So it's important to differentiate this from vitreous hemorrhage, where there's no clear space between the echoes and the retina. So I will talk a little bit more about vitreous hemorrhage later. So in this patient, the patient can undergo cataract surgery. I mean, we still have to give them a guarded visual prognosis because of possible PDR changes, but this looks more like asteroid hyalosis. Coming to another case, a 39-year-old male with a right eye injury with a football. Vision was hand movements, and the anterior segment had a traumatic hyphema. You can see we try to take an optos photo, fundus photo, but there's no view of the retina as such. You can see the optic nerve little hazily. In this, a B scan is very important, especially in trauma, to rule out any kind of posterior pathology, which can be retinal detachment or tears, vitreous hemorrhage, PVD, or choroidal hemorrhage. So what kind of treatment we need to give the patient is based on what we actually see on the B scan. So let's go through these different pathologies that we can find. The first is a low reflective membranous echo, which can have either an incomplete attachment as the bottom left picture or a complete attachment which is freely mobile and not attached to the optic nerve head. And this membrane usually has a good after movements, and it is a posterior vitreous detachment. So in the video up, you can see that it's a slightly more highly reflective, but it still has good after moments. And this could be a bloodline PVD, which we can see either in PDR or we can see in traumatic cases. Coming to the next possible thing that we can find in this patient is vitreous hemorrhage. So in vitreous hemorrhage, you can see multiple low reflective mobile dot echoes and short lines in the vitreous with low amplitude spikes on the A scan. But with organization of the hemorrhage, these can become membranous with higher reflectivity, and denser hemorrhages can increase in opacities with even more higher reflective echoes. The other possible diagnosis is retinal tears. So there's a focal discontinuity or a flap-like elevation that we can see in these two pictures of the retina with adjacent localized vitreoretinal traction. It can be associated with a minimal amount of subretinal fluid, and it will have very slight after movements on a dynamic B scan. The other possibility in this patient can be a frank retinal detachment. So retinal detachment is seen as a high reflective membranous echo with a corresponding very high reflective A-scan spike, as you can see in the bottom video. And it will have attachment to the optic nerve head with poor after movements. So this is very diagnostic of rhegmatogenous retinal detachment with a high spike and poor after movements. The other possibility in this patient can be choroidal detachment, where we can see these smooth dome-shaped and high reflective membranes. And very typically, they do not have attachment to the optic disc, and they do not have any kind of mobility. And on a scan, you will see a double high spike called the M spike, which is the retina and the choroid. So in choroidal detachment, it's also important to see whether it's a serous or a hemorrhagic choroidal detachment. A serous detachment in the first picture, you can see there's an echolucent space behind the membrane, whereas in hemorrhagic, you can see multiple moderate to high reflective dot echoes behind the membrane. So in our patient, thankfully for him, he had, as you can see in the images, he had an attached retina with low reflective dot echoes. So he underwent a conservative management. He was treated for his high eye pressure, which he had because of the hyphema, and he was also started on topical steroids. And 2 days later, you can see that there's almost complete resolution of the hyphema with a very good view of the fundus. And we can just see a Berlin's edema in the superior portion, but none of the possibilities that we saw on the B scans. So B scan was very crucial in this case for appropriate management, because if we saw any one of them, especially retinal detachment or retinal tears, we would have gone in for surgical intervention. So this is a table which is available in almost all textbooks, everything, where detachments, we need to know the difference between PVD, RD, and CD. And I'm not going into that specifically, but it is a very important and easy way to remember. So coming to another case of trauma, in this patient, you can see in this scan where he has two membranes. So one is a 360-degree serous choroidal detachment. You can see the echolucent space behind. It's very shallow. You can also see an additional membrane, which is the retinal detachment. So in this patient, and there's also a lot of vitreous hemorrhage. The vitreous is showing plenty of mobile, low reflective dot echoes. So this patient of trauma, he will need surgical intervention, unlike our first patient. Another use in trauma is in cases of IOFB, that is intraocular foreign bodies. It's a dense, bright opacity with acoustic shadowing of the ocular or orbital structures, as you can see in the image. It has an extremely high reflective echo. And in spherical foreign bodies, you can see a reverberation behind it, and it will persist in low gain settings. That is, even if you decrease the gain, you can still see the persistence of these IOFBs. So in trauma cases where we're suspecting an intraocular foreign body, whether you can see it or you cannot see it, a B scan is still recommended to identify the exact location. So since we spoke about retinal detachments, that was rhegmatogenous. Coming to a case of PDR with tractional retinal detachment, in this, similarly, there will be a high reflective membrane, but this will have a concave structure and an immobile taut membrane with multiple points of vitreoretinal attachment, and it's often tented towards the optic disc or the fibrovascular membranes. And coming to another case, a 28-year-old female with sudden bilateral vision loss, headache, and tinnitus. The pupils were non-dilating due to posterior synecdoche and inflammation, so there was no fundus view. So you can see in this picture, there is a high reflective membrane, and this reflective membrane is changing shape when you shift the position of the patient. So it has some amount of shifting fluid, and this diffuse choroidal thickening in both eyes, and the vitreous is showing some moderate number of low reflective dot echoes. So this patient was diagnosed with OU Koyanagi-Harada syndrome, and this is a case of exudative retinal detachment. Coming to another case of a 2-year-old male with parents complaining of white reflex in the left eye. There are multiple reasons for leukocoria, and these are mentioned here. But what is very important to recognize, and we need to take a very good history for this as well. So coming to what this patient had, this shows an irregular contour with a high surface reflectivity, an internal medium to high reflectivity echoes, and internal calcification with orbital shadowing. It may or may not be associated with retinal detachment. And this is a retinoblastoma. So it is very important to do B scans in retinoblastoma to see the extent and also for the prognosis for the patient. It's also useful in other tumors. For example, this is 60-year-old with mass lesion in the left eye. You can see a dome-shaped or collar button mushroom type of lesion with low to medium internal reflective echoes and sound attenuation. That is angle kappa. That is the top of the A-scan spike will keep decreasing as you go through the lesion. It has a regular internal structure with internal vascularity and a collar stud pattern and a presence of acoustic hollowing. So in this, it's important to measure height and base for treatment options and to see how it's responding to treatment. So this is a case of choroidal melanoma. Similarly, it can be used in choroidal hemangioma, where we see a dome-shaped subretinal lesion with regular internal structure and no vascularity with a high internal reflective echo spike. And we can also use it in choroidal osteoma, where we see a mildly elevated mass-like appearance with marked shadowing. And if it's present on the optic nerve, like in the inferior picture, you can see that it's showing a pseudo-optic nerve appearance, and it has an extremely high reflective echo. So coming to one of the main reasons we use B-scan is a case of 53-year-old patient with 2 weeks post-cataract surgery with a streak hyperpion and a hazy fundus view. You can see low to moderate reflective dot and membranous echoes in all the quadrants. The retina is attached. So this is the case of endophthalmitis. It can have similar echogenic appearance to vitreous hemorrhage. That's why history is very important. Loculations can occur, and endophthalmitis typically has retinochoroidal thickening, as you can see in the bottom picture, and poorly defined ocular coats. Often it obscures the optic disc and the retinal view. So there are a few points that you can differentiate between VH versus inflammation. I'm just going to focus on a couple of them. Vitreous hemorrhage is usually dependent and it settles inferiorly with gravity, whereas in endophthalmitis, you can have diffuse throughout the vitreous cavity. And when you're doing a dynamic B scan, vitreous hemorrhage is more mobile, whereas inflammation is less mobile. And of course, clinical context is very important in this case. So this case, after vitrectomy and IOAB, intraocular antibiotics, you can see that there was a clear vitreous cavity and there was vision improvement. So another case, a 35-year-old female with suspected right eye papilledema with vision 6-6 in both eyes. You can see that the right eye looks like the disc margins are not very clearly defined and the left eye is normal. So right eye showed this, which is a very high reflective echo over the optic nerve head persisting in low gain, which is suggestive of an ONH drusen. So this is a case of pseudopapilledema. She need not be treated for papilledema or optic neuritis. It's just a case of optic nerve drusen. Another case of 32-year-old who was complaining of a moving floater, suspected to have cysticercosis. And you can see this scan which shows hyperechoic edges with an anechoic center in the vitreous, and it is mobile on dynamic scanning. This is a simple vitreous cyst, and it needs to be differentiated from cysticercosis because the treatment is absolutely different. You just have to observe a cyst, a simple vitreous cyst. So the echo pattern will be anechoic and a vitreous cyst internally. Cysticercosis might have internal echoes with presence of debris, and it will also have an echogenic scolex. The mobility, vitreous cyst is more commonly freely mobile, whereas cysticercosis will have restricted or attachments to the retina as well. So, and another main reason we use this is posterior scleritis for diagnosis. The T sign is a fluid accumulation in the subtenon space. It is seen as a hypoecholuscent area continuous with the ONH, and B scan is diagnostic in this case. We also can use it in silicone oil filled eyes, although it's not very accurate to detect retinal detachments, and the eye appears longer than normal because the speed of sound in silicone oil is much slower, and a prone or sitting position is preferred to scan the normal ocular wall. Other few conditions that we see it in is in hyperreflective globular shadow, which you can see in the inferior vitreous in the first scan, which is a sign of dislocated lens after trauma. And in glaucomatous optic nerve, in case of no view, we can use a B scan to see the prognosis again of the eye. But it's best seen in the vertical transverse and longitudinal scans. And excavation of the optic nerve head is noted, as the arrow is pointing to. And a CDR of minimum 0.5 is required to be detected by USG. So clinical PERT's gain adjustment is key. The probe orientation, you need to understand probe orientation correlated with the clock arc and the meridian. Use coupling gel generously, and dynamic scanning is important to differentiate between the different membranes. And always scan both eyes and compare, because you need useful baseline and comparative anatomy. So although newer retinal imaging modalities exist, B-scan still remains the gold standard in several conditions, especially when the media opacity precludes direct visualization. Thank you.
Excellent talk, very crisp, all points beautifully highlighted. I just want to ask one question. Is there any situation in injury, in a trauma eye, probably a large tear or something, where you would suggest not to do B-scan?
Yeah, if it's an open globe injury, preferable to do the first surgery first, and then when the eye is stabilized, and then we do the B scan. So usually we don't do the B scan in an open globe injury unless the first primary repair has been done.
Yeah, that is correct. MPB ma'am, you want to add something, ma'am? And Dr. Sriram?
Ma'am, with you being a co-panelist, I'm not going to open my mouth on B-scan, ma'am.
You can, most welcome. Very nice talk, Sashwanti, and I'm glad you're continuing your interest in B-scan. Probably one thing I would say, if you have acute trauma and you want to image, say it's a road traffic accident or polytrauma, and you have an open globe, then a CT scan is advisable, because you would want to look at is there a foreign body, is there a head injury, and then you will image brain and orbits. So that's what I would like to say. But if it's an open wound, which is reasonably, it's a small one and you still want to do it, we have tegaderm in our emergencies. So we can put a tegaderm over the closed lids. So then it avoids carrying infection inside. You have to be gentle, but yes, you can use tegaderm. But probably two things you should not miss on a B scan is missing a retinoblastoma in a blind eye, because sometimes it just sits there and you have a child who's not in the typical age group. So you just say this is a blind eye, nothing to be done. And then you find it's harboring a retinoblastoma and an intraocular foreign body post-trauma. So those are two things that you cannot afford to miss. Missing an RD is okay, but missing a tumor or melanoma in an eye with, say, vitreous hemorrhage, it's rare, but it can happen. So these are things that you cannot afford to miss, which is why it's important to look at the clinical history and clinical findings before you do the ultrasound.
I agree, ma'am. First time you see a patient with a blind eye, at least document the scan that there was no mass lesion in the eye when you first saw him. I totally agree with that. And your last point was very important, that look at the fellow eye, especially when you have no view of the fundus like a total cataract. You do a B scan, you find few echoes. Always looking at the fellow eye where you can see the vitreous, and if shows similar echoes, that actually helps to differentiate whether the echoes are normal or not. And to quote MBB madam, what she told me more than 2 decades back, an acoustically clear vitreous can be optically hazy and vice versa. I still remember that statement. I'm just add to one more point. Between a PVD and an RD is usually attached to the edges of the optic nerve. Whereas a PVD invariably is a point attachment. It's not a broad attachment at the optic nerve. RD will usually go to the edges of the optic nerve. That's one small thing I wanted to add. And for general ophthalmologist, before any cataract where you can't see the retina clearly, always do a B scan. I'm sure Dr. Murali is still online and he'll agree. The medico-legal importance of having a normal B scan, irrespective of what the fundus contains, how your surgery goes, the medico-legal importance, I know at least few of my friends who got saved from serious litigations just because they had a normal pre-op B scan. And that stands really in good weight in court. Thank you, ma'am.
In a blind eye where you want to rule out tumor, what is the frequency of repeat scans that you should normally do? 5 years or 10 years? Ma'am?
No, I think you have to look at it in the context. Is it the tumor which caused the blind eye in the first place?
No, no.
Unlikely that it is going to grow or anything, though you would need, if you are suspecting a tumor, then you'd remove the eye. I don't think you're looking at following it up.
Okay.
But if
That's
you
what I said,
see
ma'am. First
that,
time,
yeah, the
first time you see a
time,
patient,
yeah.
if one eye is blind, PL, no PL or something, eye is sort of semi-thysical, don't just ignore that eye and start seeing the other eye alone. First time you see him, do a B scan, document there is no mass, and then you forget about it.
Now, one quick question. So when you have a corneal ulcer and then you have hypopyon, pseudophakic eye, and you see some echoes, which are a little more than the other eye. Okay, I've covered all the points that you have told me. Now, how is there a way of saying that you're dealing with inflammation or early endophthalmitis?
Or?
Early endophthalmitis.
Early end of, or is it normal corneal ulcer with a few echoes slightly more compared to the other eye, ma'am? Is it going in for end of or not? Correct,
I
ma'am?
think
Did I get your question
she's
right?
looking, is it the cornea going to end off or end off going to the cornea?
I think I'm talking about quite often when you're talking about corneal ulcer and do ultrasound and you have echoes little more than the other eye and say it's a pseudophakic eye, there is a possibility of spread. Then when you say echoes are little moderate, is there a way of distinguishing whether we are dealing with an early inflammatory spillover inflammation or an early endophthalmitis?
Maybe serial B scans, if it's not too many echoes difference between the two scan, maybe serial B scans if you're already started treatment for the, so and then if it's increasing, then we will definitely err towards end off and treat it that way.
Okay.
Because we see similar things of spillover inflammation in patients with buccal infection, where, it's just a little inflammation, but there's no breach in the surface. And you remove the buccal from outside and an inflammation settles down. So that we do not call endophthalmitis. It's just a spillover inflammation.
The real reaction.
Yeah.
Okay, thank you.
Ma'am,
Another case, since we have a combined glaucoma group as well, I think serial B scans or biometry is important in children with congenital glaucoma. And when you see the axial length increasing, then it is a red flag.
Yeah,
Correct me if I'm wrong, Prasanna.
very, very important point.
I think absolutely. It's very important to measure all aspects where we routinely do axial length, corneal measurements, and a biometry. And it's very important in the follow-up of glaucoma, especially childhood glaucomas. And I think she also mentioned about looking at the optic nerve in advanced glaucomas. And I probably would slightly differ with her that it's very difficult to pick up a glaucomatous cupping on a B scan unless you are really proficient, you have some extraordinarily skilled technician who does the B scan. And maybe if we can do a classic complete glaucomatous optic, cupping, like total cupping, it's probably you can pick it up. But otherwise, it's difficult to estimate glaucomatous cupping so easily with a routine B scan. Maybe the B scan experts could let us know, is it really useful in estimating cupping? Is there anything new in the way we estimate, if possible to estimate cupping of the optic disc using B scan?
Ma'am, you first, ma'am.
Dr. Murli, actually, it's more of a prognostic thing when you have a patient with a total cataract or you have a patient with a corneal opacity and you want to know whether it's worthwhile proceeding with surgery. And if you pick up glaucomatous cupping, like Sashwati showed us that case, then you probably think twice about advising surgery in terms of prognosis.
Okay. Is some kind of prognostication okay.
I just wanted to add one point, ma'am, that cupping which is picked up on B scan is also relative to your disc size. So somebody with a very large disc, which need not necessarily be glaucomatous, your B scan will show some amount of cupping. So it is very much relative to the disc size.
That in those cases, comparison with the other eye, if possible, can also
to some
give
extent,
you
and especially when you can see the fundus in the other eye.
Yes.
Thank you, dear panelists. We'll move on to the last speaker of the day, if that's fine. Yeah. Manjula ma'am, can we have the screen? Yes, so next we would like to invite Dr. Vaidehi Bhatt, who's completed a fellowship in medical retina and currently pursuing fellowship in pediatric as well, and extensively trained in cataract, retina, and pediatric eye care with a holistic approach. And she has developed advanced skills in ophthalmic imaging, diagnostics, and hands-on experience at the UBM Institute, Mumbai. And she has published various papers in national and international index journals, and the recipient of the Best Free Paper Award for Ophthalmic Imaging at BOA and at the Best Paper Presentation at MOSCON. Over to Dr. Vaidehi Bhatt for the talk on UBM.
Thank you so much, sir, for the kind introduction. First of all, I would like to thank Dr. Sujata Mohan ma'am for giving me this opportunity. My topic for today is ultrasound biomicroscopy in short. UBM we use a 35 to 50 megahertz probe. It is a high resolution anterior segment imaging modality with a resolution of up to 40 microns, and the depth of penetration is 4 millimeter. It is an excellent tool for diagnosing anterior segment and anterior orbital pathologies. Here we have the normal anatomy of the eye as seen on UBM in a phakic patient and in a pseudophakic patient. The angle of the eye is by far one of the most important indications why we would do a UBM, especially in cases where slit lamp gonioscopy are inconclusive or you have dense media opacities and you want to look at lesions beyond the iris in the ciliary body or in the zonules. UBM is excellent to visualize that. Scleral spur is an important landmark when we are doing a UBM. It is the line joining the sclera and the ciliary body where it hits the angle. This is the Schwalbe's line, and here we can see the trabecular meshwork. A few important conditions in glaucoma where UBM can be diagnostic. First, we start with plateau iris configuration. In this, the iris root is inserted anteriorly. There is medial rotation of the ciliary processes, an absent ciliary sulcus, and the central anterior chamber is usually normal, well formed, or it may be slightly shallow. The next condition we go to is malignant glaucoma. It is a secondary angle closure glaucoma in which there is aqueous misdirection. So here we have a blockage of aqueous at the pars plicata region, so it goes into the vitreous cavity, causing iris lens diaphragm to get pushed forward and shallowing of the anterior chamber. So when you have an elevated IOP with a patent iridotomy, you can think of malignant glaucoma, but the posterior segment should be normal. Here we have two conditions, two clinical diagnoses which can present with similar clinical picture. So a patient coming to you in the OPD with dense corneal edema, very high pressures, shallow anterior chamber, you have very poor media clarity, you slit lamp gonioscopy, ASOCT are inconclusive, you do a B scan, it is normal. Then how do you know what is the pathology? You can do a UBM, and in the figure on the left, here we see corneal and iris apposition. There is a flat anterior chamber, posterior chamber is well formed, IOL is pushed backwards. So this is a case of synechial angle closure, whereas in the image on the right, the iris lens diaphragm is pushed forward and you have medial rotation of the ciliary processes, and AC and PC both are shallow. So this is malignant glaucoma. So this is one of the important indication where UBM has helped us in diagnosis. Posterior polar cataracts, the defect in the capsule in cases of dense cataracts can be determined with the help of UBM. On the image on the right, we can see a defect in the posterior capsule, whereas left, the posterior capsule is intact. Supraciliary effusion is a condition in which there's accumulation of fluid in the supraciliary space. It can push the ciliary body forward and cause secondary angle closure, and here it's pushed the iris forward. So slit lamp and indirect ophthalmoscopy may not pick up this lesion. So here UBM is again useful in identifying this condition. Descemet's detachment can be visualized on ASOCT as well as UBM. Here we have on the on right, there is a Descemet's membrane detachment as well as a tear. Or to know the cysts or tumors in the anterior segment, their size, their contents, their extent and infiltration into the structures of the anterior segment can be very well visualized with the help of UBM. Here we have a ciliary body cyst in the first image. The lower image is of a iris cyst pushing the angle forward and causing angle closure. Here we have multiple irises, and the image on the top right is of an iris cysticercosis with scolex, which we can see inside. He had few cases of anterior segment cysticercosis. Two patients were referred to us with conjunctival cysts to know their contents and extent of the involvement. So here on doing UBM, both turned out to be conjunctival cysticercosis. We have a thin walled cyst with a bright echogenic scolex, dense inflammation surrounding it, but the sclera doesn't appear involved. There's a clear demarcation line. So both are conjunctival cysticercosis. And this helps us in planning, surgical planning or medical management of the patient. Here we have a limbal tumor and which is not infiltrating the sclera. So it's a pigmented lesion. ASOCT might be difficult, so your UBM is useful. This was a middle-aged female having localized scleritis since a few months. The cause could not be determined. On doing UBM, we see echogenic mass lesion in the ciliary body. It is a ciliary body granuloma. IOL positions, especially in cases of UGH syndromes, we can know the exact location of the optic and the haptic in the anterior segment. So the first image shows the optic in the position, whereas the haptic is rubbing the ciliary sulcus. The image on the right is of a capsular block with pupil block. And on the lower image, we see the IOL, optic and haptic are rubbing the iris structures. And the last figure on the right bottom, we have multiple membranes in the pupillary region. In the posterior segment, IOL is pushed backwards. Post-cataract surgery, recurrent corneal edema, retained lenticular fragments can be one of the cause. Here we have a retained fragment in the angle of the anterior chamber, and here there are multiple fragments surrounding the ciliary body in the posterior chamber. On the left side, we have IOL dislocation into the vitreous cavity. And this in the right, there is an IOL subluxation. The haptic is rubbing the ciliary process, and the nasal optic is rubbing the iris. So even the exact positions of the zonules, or if there is a tear or even stretching, can be known with the help of UBM. Blunt anterior segment traumas can lead to hyphemas and multiple conditions. Here we have done a UBM in showing angle recession on left. In the image on the right, there is ciliary body detachment from the sclera. The anterior chamber is communicating with the supraciliary space, and there's a case of cyclodialysis cleft with a hemorrhage within it. So in conclusion, UBM is very useful in conditions having dense media opacities, opaque cornea or anterior chamber, hyphemas or dense inflammations, to evaluate the angle structures, difficult angle structures, and in cases of intractable anterior uveitis, scleritis, or anterior segment and conjunctival lesions, which may be pigment, even like dermoid or the cysts, to know the contents, hypotony and ciliary body lesions. In anterior segment trauma, even foreign bodies can be determined, and we can know the IOL positions and their complications, and also we can know the sclerotomy sites, whether there is proliferation in that area too. I have not added that slide due to paucity of time, but in those conditions UBM is useful. Thank you.
Thank you, Dr. Vaidehi. Murli sir, you want to add your points, sir?
I'm not sure if he's online. I'll just say one point.
Yes.
Regarding that retained lens fragments, it cannot be stressed more, especially somebody who's had cataract surgery uncomplicated. keeps coming back with repeated bouts of mild or moderate inflammation. You're not able to find anything, never progresses to an end of first or second episode. I usually wait, but after that, invariably, I think a UBM is mandated so that you're clear cut ruling out any retained lens fragments behind the iris. Even in the angle, you can do a gonio and find out, but once behind the iris, especially if you operated on a small pupil, it's very highly likely one small chip is stuck behind the iris. So I think that's the first thing we should be ruling out before looking at anything else. Talking about an uncomplicated surgery, IOL in the bag.
Yes.
Another important thing is looking at the zonules, especially in traumatic cataract, when there is a subluxation, or you can know the extent of zonular dehiscence or weaknesses that will help you prepare for your cataract surgery, whether you need rings or, Sioni or which type of lens, all of those things. So that is one thing which we do routinely.
So can I make a point, Vedita?
Yes,
So
please.
an excellent presentation, all points well covered. Like you said, as an extension of understanding the zonules and lens position, especially in cases where you have corneal decompensation, you want to do a preoperative UBM to see the position of the lens, because sometimes it may have to be combined with a PK or an EK. If the lens is decentered, then that you will get a fair idea about how well centered or not centered the lens is, and whether you need to do additional procedures during the time of your surgery in the form of SFIL or repositioning the lens. So I prefer to do UBM in cases which are pseudophakic, badly traumatized pseudophakia, where the cornea is decompensated, to understand that. The second point I want to make is, I also feel that when you have densely vascular, apart from the tumors that you said, to understand scleral invasion and pigmented or keratinized lesions, when you have densely vascular lesion, like even a conjunctival hemangioma for that matter, both the internal structures and the posterior extent are much better visualized in UBM than in OCT. So it does help to do the UBM, especially if it is full of blood. The third point, both UBM and ASOCT have a limitation. If you have lesions in the fornices, it becomes very difficult to image the lesions, whether it is ASOCT or UBM.
No, ma'am. Your thoughts, ma'am? Especially on AHFVP, ma'am.
Yeah, before that, probably I'll just, a very nice wedding, very nice presentation. Probably in malignant glaucoma, one wants to differentiate between ciliary effusion or no ciliary effusion, because then you decide whether you go for your medical line of management or you have to go to surgery to relieve the block. Then it's also very important to diagnose plateau iris, because I probably would disagree with your choice of image for plateau iris, because plateau iris has a very typical configuration on UBM. The absolute flat iris with the iris roll, which you see at the end, which is caused by the bulky ciliary processes pushing against the peripheral iris. So I think a lot of glaucoma specialists now suggest UBM before they do a PI, because you would like to rule out plateau iris. And also pigment dispersion to see the amount of iridozonular or iridolenticular contact. Anterior hyaloid proliferation, yes, we do UBM. And only thing is you have to differentiate it from vitreous getting stuck in the sclerotomies, especially in the era of 25 gauge and all that, where you depend on the vitreous plug to close your sclerotomy. Whereas in the old ones, it was always very clear. So yes, it's important. Fibrovascular proliferation at sclerotomy sites causing late vitreous hemorrhage, not immediately in the postoperative.
Ma'am, regarding plateau iris, ma'am, apart from the ciliary body, which we cannot obviously visualize on a OCT, can anterior segment OCT itself give a decent idea about the iris configuration?
I think it should, Prasanna.
Ma'am,
The ciliary body won't be seen, but you'll see the configuration of the iris and it coming so anterior.
The role, the peripheral role of iris is what we pick up.
So the anterior OCT, yes, sir, but nothing like the UBM, because as ma'am told, we need to see the peripheral role of the ciliary body would be much appreciated better with the UBM, sir. And another point which I wanted to add is with the new procedure called ECP, endocyclophotocoagulation, another advent of MIGS that has recently been come. most of the angle closures that we treat with ECP, so we go behind the iris and with an 18 nanometer diode, we treat the ciliary body, and we tend to see the shrinkage and the pulling up effect of the root of iris as well, and the angle actually opens up. So that is another one which we are recently coming up with a paper from our center as well. An endocycloplasty that we assign that we see with the angle closures, and other MIGs also, the trabecular meshwork excisional procedures, Suchagat, KDB, Bank. So there is much more that we are seeing, and it really gives a lot of illumination on angle closure glaucomas mostly.
Dr. Sujata, you want to add something?
No, it's okay. I think the discussions have been fantastic and the speakers have been fabulous. I think we really learned a lot. I'd like to thank all of you for staying back, and can we take a picture, Prasanna?
Yes, ma'am.
Dr. Rama and Dr. Sashwandi, please come. Dr. Sashu? Not here. Can you come? We can take a picture, yeah.
I have taken, ma'am. I will share it in the group.
Okay, thank you. And thanks to all of you. Thanks to the moderators who did a fantastic job. Of course, panelists were also fabulous. Thanks a lot for this wonderful webinar.
Thanks,
Thanks
ma'am, for
to
inviting us. Yes,
Good night.
Thank you.